in terms of many of my classmates and what this area of healthcare was like and what we needed to be doing and thinking about, which really led into, over time, our desire to build this program. And myself and a couple of other medical students at the time worked hard the first few years to get this going. So the Four Directions Summer Research Program, really, I think our ultimate goal was that we want to improve the health status of American Indian communities. There's a lot of ways to do that, providing direct care to those communities, doing research around the health of those communities. But one of the areas is ensuring that we have a diverse workforce that can, that desires to and can take care of those communities. And that was really the goal, that, or the objective that we were pursuing in the Four Directions program. I feel like we do a couple of things for our students. We introduce them to research and health careers. We are trying to create leaders who can then go back to their communities or other communities and serve as role models. And ultimately, we also are trying to establish this network of American Indian health professionals, which we felt like was a big gap in this area over time. I didn't come with a lot of data around the statistics of American Indian health professionals, but you know, right now, less than 0.5% of the physician workforce is American Indian, which is, you know, at least a five-fold difference in terms of their representation in the population. So there's a real dearth of American Indian health professionals, and in rural communities in particular, American Indian reservation communities, you know, there are 20 to 30% gaps, vacancy rates in physicians. So there's a real desperate need for clinicians in those areas. Our program, as we've tried to design it, I think of our program as really addressing two fundamental issues. So one are interpersonal barriers that our students come with. And so what I mean by that is some of the things that you're talking about, it's sort of what's my inner perception of who I am and my perceived abilities to succeed in this area, my motivation to pursue a career in medicine. And then we see this a lot among American Indian students, my fear of isolation. So when I get to medical school, will anyone else there be like me or have a shared experience for me? And we work on that a lot because the truth is, right, there are, I don't know how many medical schools there are right now, but let's say there's 120 or so medical schools. There's about, you know, 90 or 100 American Indian students that enter medical school every year. So there's a really true fact that they will be isolated, and how do we deal with that and still encourage folks to persevere? There's a separate set of barriers which are, in my mind, entirely structural. So those are barriers like financial, how do we afford medical school? Mentoring, so many American Indian students who enter medical school were in colleges that weren't offering enrichment programs or career building programs, and so, you know, there's a real lack of mentoring. And you know, the lack of availability of participation in enrichment programs really does hinder their career development over time. So what does our program do? So we provide a mentored research experience here in the Longwood area. We provide, and I always describe that to students as being about 80% of the time that they spend with us. So they are really, you know, spending a big chunk of their time in labs, in research settings, with a specific research project. The second thing we provide them is career development. So regularly, we have Harvard faculty and other senior administrators come meet with them and describe to them what they do. What are the biggest barriers that I had? And actually, a lot of how I focused the development of our program was really kind of filling in gaps that I felt like I had in my own knowledge or when I was applying to medical school and going through medical school. So the career development, we have folks sit down with them who are full-time practicing physicians, or running a research lab, or being a healthcare administrator, or an educator, or a teacher, just so they can get a sense of what are these different jobs like, because for many of them, they haven't experienced any of these career options and haven't had really social contacts to their family or otherwise that could let them know what these career options are like. We run a talking circle, which is a traditional American Indian sort of gathering where we can share open and honest experiences with each other on how the summer is going, what we're thinking about in our lives, what we're worried or stressed about right now. They do clinical shadowing, so they spend time with largely physicians, although we do arrange other experiences as well based on our students' interests. And then we do lots of social networking events. I always tell the students, they think that what we're doing is throwing parties for them. What we're really trying to do is establish a network for them so that when they leave, they maintain those connections that they've made with each other and with other, hopefully, faculty around the Longwood area. And I think that's a really important point. And when we think about funding, it is very hard to get funders to buy into that because they think I'm just buying them lunch or buying them dinner, and they don't want to pay for that, especially the NIH. And so it's really, really, though, important. It's a really critical piece of these programs is to develop those social connections between them. So I also tell everyone it's not just a summer program. So it's an 8-week-long experience that they're here, but we mentor people forever. So we've been doing this for 22 years, and so we continue to mentor people, throughout their whole career. We help them as they develop their applications to whatever it is that they're interested in applying to, whether it's always graduate school, but whether it's master's in public health programs, PhD programs, medical school, and try to provide them counseling at every step in their career because you will always feel like you need more help. And we try to draw on the resources of Harvard to continue to help all these students as we go along. So when I think about have I designed the program to address the barriers that I just laid out to you, these intrapersonal and these structural barriers? The intrapersonal barriers, our students ask a lot about, how did you pick my research project that I got assigned to? Remember I told you they spend 80% of their time in research. There's a lot of their time. 4 out of the 5 days in the week they're expected to be in the lab. So am I trying to create research scientists here? And the answer is that that's not what I'm trying to do. What I'm trying to do is to put them in a very competitive environment, a Harvard lab, right? And in an area where they may not have known anything about before, studying genetics or studying, embryos or whatever else that we're studying in our labs these days. Something they really sort of fish out of water. They haven't experienced it to this level before. And really demonstrating to them that if I put you with the right mentor, you can succeed and you can do this. And it's a really, really important confidence-building exercise for them. It culminates in them giving a presentation in a room like this to a bunch of faculty and other students where they, for the first time are giving an oral research presentation. And that exercise in and of itself is the importance of them spending 80% of their time in the lab. It's not because I think they're going to go on to open their own lab studying that particular disease. It's really a confidence-building exercise. So when I match people up, I don't actually even ask any of our students what they're interested in for a science topic. I match people up based on what's your background and experience and what faculty mentor do I have who I think would be a good fit with you interpersonally. So that is, really how I think we work on these intrapersonal barriers. The structural barriers, I think, are actually more straightforward. We just run seminars to make sure you understand every step in the path of applying to medical school, or every step in the path of applying to graduate school. We run seminars with the financial folks, aid folks around here, so they understand how do you pay for med school, how do you pay for graduate school. Those actually tend to be a little bit easier to address than those intrapersonal barriers, which I think are harder and so ingrained in many of our students. So what have we done over the years? So we've had 100, actually I think this is probably closer to 200 students now. So we've had a lot of students over the past 20, I think we're about to start our 23rd year. So it's been a long time that we've been doing this. We really focus on program reach. Who are we reaching out to? We're not just drawing on the local population here, obviously, here in Massachusetts. We look at both short and long-term outcomes. So here's where our students have come from. Our students, the distribution of our students reflect where American Indians live. So to Joan's point, we can't recruit by hanging posters in the Longwood area, right? Because we would get no one to apply to our program. So we do a lot of recruitment largely west of the Mississippi in small community colleges, places, towns, and cities you've probably never heard of. But in doing that, we've now had representation by more than 60 tribes across 32 states and almost 100 colleges. So we have really, worked hard on this idea of recruitment. We went from the first year, we had 6 students enrolled, 6 students, or maybe it was 5 students. Not many students, and it was very easy to get in that year because it was probably 6 students out of 8 applications.
So, now we enroll about 8 to 10 students, depends on the year, and we're choosing from about 60 or 70 applications. So it's actually fairly hard at this point to get into the program, which I like having a large applicant pool because it really means that we have reached out to a broader audience at this point. We do lots of so I'm a measurement person, like in my other life, and so we do lots of measurement in this program. We ask them pre-post questions like, do you plan to attend medical school or graduate school? Have we affected your confidence to succeed? And do you feel prepared? So remember, the themes here are, am I addressing your intrapersonal barriers? And that's the confidence question. And am I addressing your structural barriers? And that's the prepared to attend question. And we're always hoping to, and you can see there that we make improvements for our students before and after they go into the program. So we're always sort of focused on that structure that I've outlined. We get pretty high ratings in terms of, this is a scale of 1 to 10. So I say these are high ratings. If I were trying to publish this, someone would tell me that my scale needs to be readjusted so that we're not getting all 1s and 2s. But I think we do pretty well in terms of the experience that our students have. Longer term is we put a lot of resources into tracking all these students. We do a lot better now with our students who've come through the program in the past 10 years. One of the problems is that, and this is sort of an age-related thing, but when we started the program, there was no internet and email, so we didn't have email addresses for people or cell phone numbers or anything. So it's harder for us to track those first cohorts of students. But over time, what we find is that probably about half or so of our students have gotten into medical school or graduate school. I always tell funders that I find that number to be a funny number because I could sort of, much like with quality measurement, I could game that system and I could make that number whatever I wanted by who I admit. So I could go across the river to Cambridge and have 5 of our students every year be from the college, and I could make that number jump up, right, to 75, 80, 90%. But we maintain that we're interested in recruiting students from smaller colleges, from places where there's not a lot of resources. And so, I feel like we are in the sweet spot of sort of 50 or 60% of our students getting in, because that means we're taking enough risk and trying to, expose the right number of students to our program. So our students do lots of different things, and this was from a couple years ago. This is what our students are doing now. Many of them go on to medical school. Many of them have now gotten to the level where they're full-time practicing physicians or on faculty in different universities across the country. When they are working, this is the type of work that they're doing. Lots of patient care. Actually, the majority of the work has been and continues to be in public health. Many of them going back to their own communities to do work in health and health-related fields. And I'll sort of end. I would say one of the areas where we're sort of laughing when Joan was talking about the different ways to communicate and how I feel out of date. We're still trying to feel our way through, how are people staying connected right now? And I feel like a few years ago, I could have felt on, up to date and said something like Facebook, but I feel like that's probably old at this point. And I don't understand completely how students are interacting right now. And we're still working on that. People tell us social networking, you can see from the survey, they say this is how they want to stay connected. But I don't know what that means entirely right now, because I fear that I'm out of date, because I am just starting to do lots more text messaging, and that's so old at this point. Running conferences, it may not be the best way for us to do it from our survey data. So I would say this is a work in progress. And I will end, one of the reasons, if you haven't guessed, that I'm so interested in this work is that I am American Indian. My family is from a reservation in northern New Mexico in the mountains. This is Taos Pueblo, where my mother was raised. And this is a community that is still vibrant today. Very traditional, no electricity, no indoor plumbing. So, an area where lots of health disparities exist, and this would be the typical kind of area where we would have lack of access to healthcare professionals for these communities. So, thank you.